listening to the Pharmacy Podcast Network.
Hi, this is Dr. Danielle Plummer, and you are listening to the MaternalRx podcast on the Pharmacy Podcast Network. Get ready to meet the dynamic Dr. Liko. She earned her Doctor of Pharmacy degree from the University of Illinois at Chicago, where her interest in pharmacogenomics began. From there, Dr. Liko dove headfirst into the field, completing a clinical residency at Monroe Clinic, where her research focused on the real-world implementation of pharmacogenomics. Following that, she pursued a fellowship in the clinical implementation of pharmacogenomics at the University of Colorado, where she honed her skills in bringing this cutting-edge science on a larger scale. Now, as the Director of Clinical Pharmacogenomics Operations at Rx Genomics, Dr. Liko is at the forefront of innovation, leading a multidisciplinary team in revolutionizing clinical operations. Let's hear her insights on using this science to change how clinicians support maternal health. Dr. Liko, thank you so much for joining us today. Anything I can add about this incredible background of yours? You've done a residency and a fellowship in pharmacogenomics, which I didn't know existed. Tell us a little bit about those experiences and how that brought you to where you are now.
Yeah, thank you. Thank you so much for having me on. I'm excited to talk about pharmacogenomics, especially as it relates to maternal health. So I fell in love with pharmacogenomics when I was in school. I learned about it, and it was just the perfect fit for me to think about personalized medicine. So when I was looking for a residency, I knew I was interested in ambulatory care, and particularly I chose residency that I did because they did have a pharmacogenomics component to it. And at that time, I was really interested in implementing the service into clinical care. So helped a lot of the research at that time had also been in mental health. So I helped with implementing that in the mental health clinics as well as in the cardiology department. That was a really fun experience, but I wanted to learn more about it, and I really wanted to have more proper training in how to actually implement it in a much larger scale. So that's what actually led me to my fellowship at the University of Colorado. I was there for about 2.5 years, learning how to implement pharmacogenomics at a much larger scale at the university, as well as their satellite hospitals. And there I learned not only about the science, but also about all the different facets that you need to really get pharmacogenomics in all of the different aspects of clinical care.
It's so needed. I think there's like two camps of people out there, some who have never heard of it, and then some of us like me who said, why is this not a standard of care? I got my PharmD in 2016 and remember learning about pharmacogenomic variations in each section of classes that we took, and didn't realize at the time while I was in school that this is actually accessible for everyone to do. There are barriers, though. We'll touch upon that in a minute, why it hasn't yet become a standard of care. So when we talk about maternal health, I've spoken with other both physicians and pharmacists who say it's decades behind other areas of medicine when we talk about personalized medicine. This is at our fingertips. Your work that you've done through these experiences and what you're doing now with Rx Genomics makes it readily accessible for almost everybody. And that's why I think it's just fantastic and excited to have you here and talk about this today. How is pharmacogenetic information used in improving pregnancy outcomes? I think that's something that we're going to break down more granular in a moment. But what are the benefits of pharmacogenetic testing?
Yeah, so when you think about pharmacogenetic testing, it's really another tool that you can use in your tool belt for how to choose the medication that's really the best one for that patient. when you think about it, we're all a little different. We even look different. So then why would we choose just one blanket medication for all of us? So that's where really a lot of the benefits are, that it's this very personalized medication regimen for that particular patient. And the main goals of it are to really help with reducing the side effects. So some of these medications, we know they have a lot of side effects. Even when we look at ads on TV, they work for certain things, but then there's a laundry list of side effects. So it can definitely help with that. And it can also help with actually making the medication work. And like Dr. Plummer said, we will get more into the specifics, but one of the main ones will be for hyperemesis for women that are taking that during pregnancy, that some of them may not actually respond to Zofran, but other women may respond to that. So pharmacogenomics can really help to narrow that down.
So for those listeners who have no idea what we're talking about, let's just take a step back, explain how the test works. So with RX Genomics, you will send the patient a kit at home. Is that correct? And they do the cheek swab. Tell us about that experience from the patient perspective.
Yeah, great question. So it's really easy. We mail the sample to the patient, and it's actually a lot easier than doing a COVID test. We're all familiar with that by now. It's just a cheek swab. You swab your cheek for 30 seconds on both sides. You're not supposed to eat for 30 minutes prior to it. And then you actually just mail the sample to us. And the whole process doesn't take more than 5 minutes on the patient side. Everything is there, provide all the actual labels and the kits that they need to send it back. Once we receive it in the lab, we'll actually run the sample through the lab and then provide the results. And we also provide a lot of support when it comes to the clinical piece of it. We have what we call a medication action plan. So it's really actionable information on how to use the genetic information and apply that to the medication. Because our goal here is to really make it accessible to every provider and pharmacist to be able to read the results really easily.
And it is, I can testify to that one myself, right? So when we talk about the clinical applications and the medication classes of pharmacogenomics as it relates to maternal health, I like to break it into the different, not even trimesters, but start with preparing for pregnancy. We have a society now where women are having more and more difficulty becoming pregnant. So there's different tests that you would look for prior to becoming pregnant to help you have a healthier pregnancy. One of them being the MTHFR gene mutation. What would we want to know about that as a pharmacist?
Yeah, so like Dr. Plummer mentioned, there's all these different steps that women need to take even before being pregnant. And one of them is to make sure that your pregnancy is supported. So folic acid is really an important component of that. And so it comes with the rest of the vitamins as well. So the MTHFR test can really tell you whether you're at an increased risk of having low folic acid or not. And in the case that you are at an increased risk, then it's really easy to replace that. You maybe can take a little bit more folic acid, do another test to see where those levels are. Whether, if you don't know that information and you try to get pregnant, or even if you do get pregnant and then you don't have that support with the folic acid, there is a higher chance of potentially the pregnancy not continuing.
And it's so important. The NIH, the CDC has done extensive research on the importance of folic acid in pregnancy to decrease the risk of birth defects like heart defects and cleft palate. But now we know not everyone should have that form of folic acid. The natural form from foods directly is folate, right? And prenatal vitamins are being made with that methylated form if you have one of these variations where you don't metabolize that folic acid to the form that our body needs. So I say that's where to begin, right? If you're thinking about becoming pregnant, take a look and see which prenatal vitamins you should start on. We also talked about different disease states that lead to problems throughout the pregnancy, being blood clots. This is something that I never heard of, having gone through 3 pregnancies myself, until I started studying this and working with pregnant women. What would we want to know about a risk of blood clots prior to becoming pregnant? What can we do about that?
Yeah, so genetic testing can also tell you whether you are at an increased risk of having blood clots or not. There's currently 2 genes. Let's say the names of them, they sound a little complicated, but they're not. When you get the results back, it's really yes or no. You have the genetic variation or you don't. Factor 2 and factor 5 Leiden. So those are the 2 genes there. And having a positive result, so meaning having a higher risk of blood clots in this gene, it does mean that the woman may have a much higher risk of that happening before pregnancy or even during pregnancy. As we know, pregnancy does increase the risk of blood clots. So there are other measures you can take, like you can maybe start on an anticoagulant like enoxaparin while you're pregnant so that you can prevent that. Whether women that don't have that risk, that have normal factor 5 Leiden and factor 2, they wouldn't need that. So we can't have a blanket statement saying that to be safe, everybody start on enoxaparin, because that's not very fun. But knowing that having that higher risk can definitely help with finding out whether you should start on that or not.
And does the test that you do, because it's not a medication, it's a genetic variation for a disease state, does that have those results as well?
Yes, we do have the results for both MTHFR and then the factor 2 and the factor 5.
So fantastic. It should be a standard of care, right? And then once you become, actually, I'm going to back up for one more moment. I was going to save this one for later. What's next in maternal health? What got me thinking was something you said, and it was about Clomid. What should we know as a pharmacist about Clomid and trying to become pregnant?
Yeah, so Clomid is one of the first-line medications that are also being used for women that are having difficulty getting pregnant. And the way that Clomid works, it needs to be activated. So in women that it cannot be activated, then it's actually not going to work for them. So I actually did a little bit of this research during my fellowship because I was just really interested in this topic. There isn't as much research out there. We have a few studies from around the world, but there's 1 or 2 studies in the US with it. So what we saw, and this is more on that theoretical side as well, but what we saw is that women that had CYP2D6 variations that actually had poor functionality of it, they were at a little bit of a high risk of this medication not necessarily working for them. So then they're going through more than 1 cycle, and then having to then for the IVF, and then having to actually change to a different medication. But now this is down the line. Maybe they're 3-4 months down the line because they've started Clomid first. So that's something to kind of look into and think about. Like I said, there's not as much research with it right now. There are a few studies in the US that have this positive results. However, there needs to be a little bit more research to have more defined answer there. But that's what's next.
So if you're a retail pharmacist and you have a patient coming to your counter picking up Clomid, months are passing, the dose increases, they're not becoming pregnant, they don't have the positive test, recommend that they go get this pharmacogenetic test done that they can talk to their obstetrician about. And you can talk to the fertility clinics as well and maternal fetal medicine specialists, whoever you're working with. And and educate them on this, because I just think so many aren't aware yet of it. So moving on then, once our women are pregnant, there are many disease states through the pregnancy that pharmacogenetic testing can incredibly benefit. So just life-changing results. My personal experience, anyone who knows me or have heard me before, I talk about hyperemesis gravidarum, the extreme vomiting in pregnancy, often medically gaslighted. It's hard to tell for so many women. Is it more just regular morning sickness? It's mild, it'll pass. Or is this something where I'm going to end up with my own end organ damage or possibly lose this pregnancy? In this case, everything is trial and error. The true cause of the extreme vomiting is the GDF15 gene, and there is no targeted med yet at the time we are recording this. I know researchers who are working with companies to develop one, but right now, we're just trying all these different antiemetics. And, you and I have talked about Zofran because, well, for one thing, it's controversial because of what I believe are flawed studies that came out of Europe. Other studies show no increased risk of birth defects with this medication. But in my own case, and my own response to the ABCB1 gene variation, I don't respond to it. And I've worked with women now who had these pregnancies, were prescribed it, told their doctors it's not working for me, and they're not believed. They're like, oh, well, you probably aren't taking it, or for whatever reason, all the old Freud, right? Where maybe you just want more attention or you don't want to be pregnant. And I'm just working so hard to dispel these myths. Pharmacogenetics, when I had one of my patients look at her results, it vindicated her. She was able to bring this test in black and white to her doctor for a current pregnancy and say, see, this medication does not work for me because of my genetic variation. What else can you tell us about Zofran?
Yeah, so there are actually guidelines for Zofran and another gene, C2D6. So they have a little bit more guidance with it. So for some women, if they metabolize Zofran very fast, it's out of their system at a really fast rate. And because of that, it's not going to work for them. So if they are an ultra rapid metabolizer of CYP2D6, then it's just not going to work for them. And there are guidelines that suggest that actually selecting another alternative that's not metabolized by CYP2D6 is much better. So we have other alternatives out there. Granisetron is one of them. I know it's a little bit more expensive, but another thing here would be to bring this information not only to the doctor but to the insurance companies and doing those prior auths and saying, hey, look, Zofran, it's not working. It is because of genetic variations. There are guidelines for it. Please consider this other medication that's a little bit more expensive. However, these women really do need it, and it will help them a lot more.
And I'll add to that, granisetron has different formulations and different brand names. So the IV is Kytril, but what's so fantastic in the United States, I don't know about the rest of the world, we have listeners from everywhere, but we have a patch called Sancuso. The patch is approved for post-operative nausea and vomiting from chemotherapy. It goes on and it stays on for a week. And the response that I've seen with pregnant women with hyperemesis has been phenomenal. I think the biggest side effect is just some itchiness from the adhesive, which some topical Benadryl seems to work fine to help there. It can keep these women out of the emergency room and off IV fluids, which is so phenomenal. A lot of obstetricians, though, will not do prior authorizations or don't know about the process, that it's actually not complicated to do. And the pharma companies, for example, the one that manufactures Sancuso, is willing to work with you. So again, I'm going to reach out to my retail pharmacy community or our hospital pharmacists. If you see these women coming back to your emergency room or being admitted for extreme vomiting, let them know that this exists. Give them the tool to bring to their provider with the pharmacogenetic testing to show the insurance companies, as Ina said, that they have failed on Dancitron. And there's another possibly superior product that will keep them out of the emergency room. And the costs there are astronomical, really. So the other classes of medications as well for extreme vomiting also have numerous genetic variations. So most of them are antihistamines, antipsychotics. We have a few other ones out there, including some antidepressants. We have mirtazapine is now showing promise. So definitely have this test done so you miss all that trial and error and don't let the disease state escalate to where it's out of control and you can't backtrack at this point. So I could talk days and days and days about hyperemesis. Something really, really important that gets missed in pregnancy is pain management. This is a specialty for, being talked about so much because of the opioid epidemic in the United States. But a lot of women, as changes in our physical body happen through pregnancy, it leads to other pain like sciatica, right? A back being out of alignment. And we're told Tylenol is the only safe pain medication. But then other studies said if you're on a lot of Tylenol, your acetaminophen throughout your pregnancy, it could, there's a correlation now, again, correlation, not causation, but with increased autism. So what can women do if we talk about other types of pain options during pregnancy?
Yeah, so there are a couple of pain medications that are affected by genetics, a couple of different classes here. NSAIDs is one of those classes as well. So ibuprofen, for example, that, we take that every day. Some of us, or we just don't think about it. You go to pharmacy, pick up some ibuprofen for some headache. I've definitely done that in the past, but it's definitely affected by genetics. So some people are going to have really bad side effects with it, and they're going to have higher plasma levels and higher concentration in the blood. So if we're talking about pregnant women, they may have higher concentrations of it in the blood, and maybe they're not supposed to take ibuprofen because of that, even though it is something over the counter. So other alternatives for that would be, for example, naproxen is not affected by genetics as much. So knowing whether somebody has decreased metabolism is important, because then we would want to avoid this and then maybe put them into something else. But also later on, if they do take ibuprofen for postpartum, it can also cause kidney damage. Again, they are poor metabolizers of CYP2C9. That's kind of the main gene there, especially if they're taking it for a long time. So those are some things to think about. Another common one that especially we used to see this a lot in the past is codeine and tramadol, especially when women are in the hospital giving birth. And this particular, especially codeine, actually, there's some cases where babies died. So a few years ago, because of the high concentration of codeine in the blood for the mom. So the mom had just given birth. Doctor gave her codeine to help with the pain. She was actually really fast metabolizer of codeine, and codeine needs to be activated. So she was actually converting codeine to morphine at a really fast rate, having a very high concentration of it in the blood. She was breastfeeding the baby. Because of that level was really high, she passed it on to the baby, and then the baby died. So there's 2 or 3 cases of the babies that actually died from this, which is just terrible. So we do have this tool that we can use to help with that, to help with knowing, well, can I take codeine? I mean, this is dangerous for those women. They, of course, should not be taking codeine or tramadol. Tramadol is the same way. But then for other women, the flip side of this is that it's not actually going to work for them. So imagine, you're in the hospital in very excruciating pain, and you're taking medications. The doctors are saying, we're giving you the maximum dose, but it's not working for you. That can be very frustrating as well. So the test can definitely help to say, hey, this is actually not getting metabolized. I don't have it in my system. We should choose something else.
And I have so much I could add to that. Is when a medication doesn't work and they're telling the doctor it's not working, like my Zofran example, tramadol would be the same way. And they're going to be looked at as a drug abuser. And they're not going to be believed that, hey, I really am at the max dose and it's really not working for me. How do you explain that in a clinical setting? This is where pharmacogenetics, again, we have it on paper. We can explain, we can tell you, and it makes sense. It's our DNA, it's in our genes. We can't change that here. So let's try medications that actually will have the safer response for us and the better efficacy. I want to back up just for a second. When we talk about NSAIDs during pregnancy, most drug resources are going to say, don't use NSAIDs during pregnancy. So it's interesting, coming from being a hospital pharmacist, we vet all of our, well, vet might not be the best word. We look at all of our pregnant women coming into the emergency room before we give them ketorolac, because it is an NSAID, to make sure they're not pregnant, just because of some studies that have showed potential embryo fetal risks with ketorolac and other NSAIDs. So it's more of a category, but then some drug resources will say, well, first or second trimester, it's inconclusive, but third trimester is okay. I've seen different responses or labels based on which drug resource we're looking at, whether NSAIDs are safe in pregnancy or not. So pretty much everybody I know is going to avoid them during pregnancy. But if you're preparing for pregnancy or, like you said, labor delivery, post-op pain, that would be a place where you would look at the pharmacogenetics of it. So yeah, still not a lot of pain options during pregnancy. I always like to throw out there, is fantastic for women in pregnancy dealing with pain. So look at the non-medication options. And if you are going to have medications, do your pharmacogenetic test to see which safest and most effective for you. And, you know, the story with codeine, it seems like a lot of clinicians don't know that it's a prodrug, turns to morphine. And in your example, that ultra fast metabolizer, now you have all this morphine in the body. And in that case, being passed to the baby, unfortunately, there's a reason now codeine isn't given to children, right? The label says not under, what is the age, 16 or 18?
Under 18, especially when they do their tonsil removals, because it was very common, and because of this, it's not given. But you know, in my opinion, you should test and see if they have that variation. And if they don't have the variation, you can still give it.
Absolutely. So if you now make it through the pregnancy, find which pain options are best for your labor, your delivery, your recovery. There's so many places that pharmacogenetic testing can support postpartum care. The big topic of conversation going back decades now is postpartum depression. And the experience I've seen is that doctors will either say, okay, I'm going to give everyone sertraline, that's been the most tested, or I'll give all of my postpartum pregnants, whatever their drug of choice is, say Lexapro, because I saw it work well in one. So I'm going to see it ideally work well in everybody. It's a very old school way of thinking. With our pharmacogenetic testing, we can look at the different antidepressants and see which would work best for them. You know, what insight can you give us on postpartum depression and pharmacogenetic testing?
Yeah, absolutely. So there are different classes here and different genes that are affecting different medications. So maybe the two main genes are going to be CYP19 and CYP6. So depending on which medication, so it's not necessarily class specific, it's medication specific. So for example, sertraline and Lexapro may not work for someone, but they may work for somebody else because they don't have that CYP19 variation. And then in a similar kind of group there, fluoxetine versus paroxetine, you know, they may work better for someone versus someone else if they don't have that CYP6 variation. So it is really helpful to know which ones to give the patient depending on those variations. Because if you're just treated as a class effect, then you may choose a medication that's affected by a particular gene, and then that medication is still not going to work for that patient. Or even if you change the class, you go from an SSRI to an SNRI, it still may not work for them. It's not necessarily because again, it's affecting the particular medication. And mental health has a lot of research, especially a lot of the very common drugs that the doctors prescribe has a lot of research. And there's also CPIC guidelines as well as international Dutch working group guidelines that can give you a lot more insight into that.
Absolutely. CPIC being one of them, right? Farm GKB, and we can put those resources in the show notes. How do you interpret these genetic results to determine the appropriate medication doses?
Yes, this is a great question. So what do you do with the results, right? Let's say you get the test back, what do you do with them? So it's really, first of all, it's really important to make sure that you're choosing the right lab. And the reason for that is because we want to make sure that we're actually testing for the right variants. Right now, the most common way of testing is still being done through PCR. So meaning we have to choose the variants that we test, and then we see what comes up positive. So that's important in translating that information from the genetic information to the phenotype. And then using this phenotype, which is really a translation, the way I explain this to patients particularly is it's our hair color, our eye color, it's a phenotype. It's what we see as being expressed. So, if you have blonde hair, somewhere in your genetics is probably coded that you'll have blonde hair, and that's what we see. So it's the same with medications and how this works in that phenotype. Then you take this phenotypic information and apply that to clinical guidelines. So looking at CPIC guidelines, the Dutch working group, there's some French guidelines out there as well. The FDA also has some information. The FDA table has that information. And then at RX Genomics, we actually provide you with all of these tools so that it's really easy for you to go into our system and create what we call a medication action plan that will help you choose if there is an alternative, help you choose the alternative drug, and then also provide you with some insights in terms of what are the guidelines, what's the best option for the patient there.
And it's easy once you've done your certification, right? In your case, a residency, a fellowship, but there's a lot that's complicated. You do want somebody who's trained in this because it's not just looking at that one variation and saying, hey, this is what we should give you. You're also looking at drug disease state interactions and other drug interactions. So much. This is really the future of medicine, but now readily available through companies like yours and these other labs that are out there. There's a number of barriers that I've encountered. I think two of the big ones being getting the providers on board to actually say, yeah, this is necessary, and changing the way they practice and prescribe medicine. And the other big barrier, of course, being the payers. What are your insights on overcoming those two barriers?
Yeah, thank you for pointing that out. I've seen that as well, and actually did a study when I was in Colorado that looking at those barriers, and the number one barrier, especially with the providers. So, what is the reason that they're not on board? And the main reason that I found what is education. So they don't feel comfortable with applying the information, and they are worried about liability issues as well. Having the information there, but what do you actually do with it? That is a worry. They're worried that the patients are going to sue them later on. So that's one of the main issues there. And to actually overcome this, we can be there as trained healthcare professionals, as trained pharmacists in pharmacogenetics particularly, and to kind of ease that and say, it's okay, we'll provide you with all the different resources and the tools, and then we will be there to actually guide medication prescribing. And when you say that, they are a little bit more open to that, and just ordering the test. And another reason is also the cost, right? So this does relate. There are some providers that are really excited about it, they're on board. However, they step back because their patients can't afford it. So there are, different ways that are available for some of this with payers, like United Healthcare actually does have a mechanism to cover the testing. You just have to test for specific genes. Medicare also covers some of it as well, as long as you put in the right diagnostic codes there, which, working directly with a provider in number one, educating them, and number two, getting those codes from them. It's a lot easier to get those codes from the provider than the pharmacist, can alleviate some of these barriers. And particularly, I don't know if you have anybody from California listening in, but in California, Medi-Cal, actually, they just announced that they will cover pharmacogenetic testing as well. So this was announced sometime last year. So there are these different options there, but I think what's really important is to educate the providers and give them new information. So talk to them about the studies, always be there as a resource, and really establish and make them feel confident to really trust your knowledge with providing them with information and making them feel confident in ordering the test.
So there's a lot you can do. I'll add to that as well. If patients are already on a pain management program or seeing a mental health therapist or dealing with other disease states like cardiology or oncology, talk to your providers about getting this test done, because the insurance companies are more likely, some of them at least, will reimburse for it, not because of pregnancy, but because of these other comorbid disease states. So it's coming. I want Medicaid in every state to cover this test. Really exciting news about California, waiting for it again to become that standard of care, for Medicaid everywhere to cover it. And for those, I was just so surprised. It's actually reasonably affordable for those not on Medicaid, but the rest of the US here, pregnant women who might need this because they might need to take medications during pregnancy. It's actually pretty affordable. So don't rule it out and think it's completely unaffordable for everybody, because the ones I've spoken to and I've worked with are very happy. I wanted to end with the patient's reaction to this. I know my experience with the patient reaction. I already shared one of the stories where this mom said, look, I don't respond to Zofran, showed her doctor, and just felt like the sigh of relief because she was believed. What is your experience with the patient's reaction to having this test result?
Yeah, the patients are usually really excited. And especially after we go through the consult, they always say, I didn't even know that this information was available to me. I didn't have, many expectations, but this has blown away my expectations. And they actually just had a patient right before our call here today. And she just did the test because she was just curious about it. She didn't, she wasn't expecting anything. And we found out a few different genetic variations from her that will actually be important to her later on. And she was young. She was in her early 30s, didn't have children yet. So potentially becoming a new mom later on. And this information was really important for her. I had some insights on heartburn medications and nausea, and as well as pain medications, along with mental health.
It's really exciting. So if pharmacists want to learn more, you have a series of PGX Clinical Pearls. How can they find you?
Yeah, so they can be found on our website, and then Danielle, we can share the link with them after this as well. But in the RX Genomics website, you go there, you type in clinical pearls, and all of the videos will come out from the recordings. But also, I do a live webinar every month now. It used to be every week. We did that for over 2 years. And we got a lot of content out there, so now we moved it to once a month. My next one is going to be March 21st, so coming up here. And then moving forward, it will be every second Thursday of the month at 3:30 p.m. Central. And then in addition to this, if you want to learn more in your own time, we also have a CE course. It's an 8-hour CE course on pharmacogenetic testing.
Perfect. I know so many pharmacists are stepping into the space, creating their own businesses out of this, using the science, partnering with doctors, partnering with payers. It is so important to improve medication outcomes for our population here, not just in the United States, but around the world. And I just love seeing this become more readily available. Ina, thank you so much for joining us today, sharing your knowledge. For anyone listening, if you found this helpful, please like and share and reach out to either one of us anytime. Thank you so much.
Thank you so much for having me. This was great.